Good morning, everyone. Welcome to those who are joining remotely. This is our 2021 Cardiovascular Prevention Grand Rounds, and we decided to kind of mix it up a little bit this year, and so we're doing 4 10-minute talks on various topics within cardiovascular prevention. So hopefully you find it of some value. Up first is Courtney Bochler. She's our Director of the Emerging Science Centers at the Foundation, and she's going to talk to us about food as medicine.
All right, good morning, everybody. Hardest part of the morning for me, getting the slides going. All right, so we're gonna talk a little bit about food as medicine. Oh, I get to take off my mask, thanks for the reminder. I don't have any disclosures besides that this looked like breakfast, lunch, and dinner for me, and usually I like to practice what I preach a little bit, so this is a little harder for me, to be honest, this morning. But when we think about food as medicine, right, we know this isn't a new concept. I think most physicians who catch any of the popular news have seen everything that's out there about the role that nutrition can play in helping us with our patients and our own health. And even for most of us in the room as physicians, when we took the Hippocratic Oath, Hippocrates himself said, "Let food be thy medicine shall be thy food." So just setting the broad picture of some of the latest statistics from Heart Disease and Stroke 2021. So when we look at NHANES, about less than 10% of adults met the guidelines of, and we'll talk a little bit more about what that means, but of eating a healthy foods. And here it's described as whole grains greater than 3 servings a day, whole fruits greater than 2 cups, and non-starchy vegetables greater than 2.5 cups. So less than 10% of the entire population in 2015 to 2016. As we break down a little bit further, there's the American Heart Association has assigned both a primary diet score and a secondary diet score. And you can see even when we break those down, which I think give a little bit more room. Primary diet being described as fruits and veggies, sugar-sweetened beverages, fish, which is essentially high in omega-3s, whole grains, and sodium as that primary score. Only about 47% of the population is meeting the guidelines there. And then the secondary score, which is nuts, seeds, legumes, processed meats, and saturated fats. About 36% of the population. And as many know and are quite familiar, huge primary prevention trial looking at risk factors showing that a Mediterranean-style diet, high in extra virgin olive oil and mixed nuts, had a 30% reduction in the risk of stroke, myocardial infarction, and death. So again, we know that nutrition has a huge role to play. I wanted to include this slide just to emphasize the role that income plays in nutrition. So when we compare from 2003 to 2015, in terms of nutrition overall, we actually are seeing nutrition improving. And so here, kind of the lower bar, the better, if you will. But when we break that down by income to poverty ratios, you can see that unfortunately, the folks who makes the least money are unfortunately improving the least. And so while there actually has been some improvement in the last decade in people's nutritional habits overall, we don't see the same distribution in folks who are impoverished. And we've also, there's been some great studies. This was Dr. Miedema brought in Dariush Mozaffarian a couple years ago for the Kevin Graham lecture in 2018, and this is a work that him and his team have done that take a look overall at how much of a role nutrition plays. And here you can see 45% of deaths in 1 year from heart disease and stroke and diabetes were linked to poor diet. And when they break it down by categories, the biggest culprits, if you were sodium, low intake of seafood rich in omega-3s, insufficient seeds and nuts, as well as a high intake of processed meats. And so this really, again, on the upper slide, you can see a breakdown based on coronary heart disease, hypertensive heart disease, types of strokes, and diabetes, and then again, on the lower graph, looking just overall at those 10 categories and comparing men and women. so that we could see which had the biggest impact. So, so what foods are best overall? I think that this is confusing to our patients. I love the slide because, again, the best benefit of things on top, fruits, nuts, fish, vegetables, vegetable oils, whole grains, beans, and yogurt. And then things towards the middle of being slightly positive in the blue. So we've got cheese, eggs, poultry, and milk, still a little bit questionable, but a little bit more positive than the things on the negative side where, again, butter, unprocessed red meats, furthering down refined grains, starches, sugars, processed meats, high sodium, and industrial trans fat. So many of us in the prevention talk about kind of a keto Mediterranean diet, but I want to emphasize that it's not straight keto. It's not that all fats are good, but we do know that too many refined grains in particular put us at a much higher risk for diabetes, which subsequently then increases our risk of heart disease. I apologize that this slide is so difficult to read, but those of you that are really interested could go take a look on your own. Again, by Dr. Mozaffarian, taking a look at all of those various foods that we talked about, fruits, vegetables, all the way down legumes, grains, sugar-sweetened beverages, and various studies that break down coronary heart disease versus stroke versus diabetes and the relative risks for those different food groups. So really helpful. And I think what is confusing for many of our patients, and probably a lot of you know, is that what might be beneficial for coronary heart disease and stroke is not always beneficial for diabetes, and more confusing, cancer. And so for folks who have many things, that's where it gets more difficult. So we'll talk just a little bit about that. The price is just getting astronomical, and so this was a validated microsimulation model. It's called the CVD Predict, Cardiovascular Disease Policy Model used for risk, events, detection, interventions, costs, and trends, which is where they get the CVD Predict. And it's used to estimate annual cardiovascular disease, fatal and non-fatal MI, angina, and stroke, as well as type 2 diabetes costs. And so you can actually see here the prediction of these 10 different food groups and overall the cost attributable to either not eating enough of them or eating too much in the sense of processed meat or sugar-sweetened beverages. So $50.4 billion a year is, again, what's attributable to how things could be done differently, which equals about 18% of our total cost within these categories. So I want to do more than, talk about the problem and just emphasize that there are solutions. This is a program that California is doing. So MTM, or Medically Tailored Meals. This program started in 2018, and this is for essentially Medicaid patients in California, or Medi-Cal patients who were admitted with heart failure and have a history of being a high utilizer of health services and are likely to be readmitted within 30 days, which again is many of our population here. And you can see what the intervention was. They had medically tailored meals, medical nutrition therapy, and information and referral services. So this, just want to emphasize, was something that the legislature paid for and starting again in April of 2018. It's a 3-year study. It's $6 million. They're going to have 1,200 people in this study where they're going to be then able to analyze the costs and subsequent decrease in admissions and overall utilization of healthcare. So having worked at the Department of Health, I think that these are the kind of things that a lot of the nutritional societies are pushing for. Mozaffarian himself has moved his work to some of that policy level of how do we make it easier for our patients to get what they need, recognizing it subsequently at how much less it can cost. I wanted to throw this slide in there because this is the other one that I use with many of my patients that have comorbid diseases beyond coronary heart disease, stroke, and diabetes. This is the anti-inflammatory food pyramid. And this is great for people who also have cancer, which is really the only other one, or perhaps some rheumatologic diseases or things with higher inflammation levels. But the big difference there is dairy for some of those other conditions definitely has been found to be negative for cancer patients. Obviously, if calories and things are an issue and you just need to get food, it's a different issue. But what I would emphasize is the bottom half of the pyramid on basically any pyramid is very similar. The emphasis on fruits, vegetables, whole grains are not the enemy, but have to be mixed in with, as you see here, healthy fats, 5 to 7 servings a day, a lot higher than most of us get. Fish and shellfish, and then the only thing that's, again, real difference here is that other sources of protein, which is going to include all dairy, all poultry, all animal meat, 1 to 2 a week. So it's much more plant-based for folks who need that. Lastly, just talking about functionalizing food as medicine and what we're actually trying to do here. This is a pilot that we have gotten IRB approval for, where we're working in New Ulm with Hy-Vee and Benefit, which is an app developer. And again, I think most of you are not surprised by any of this, but the question is always, how do we move to behavioral change for patients? What's sticky enough to make this work? And so one of the interesting places is the grocer. Grocers make more when they sell fruits and vegetables. So if that's part of what we're trying to do is to get people to be eating things out of a box, or excuse me, not out of a box, then how do we sort of impact that? And so you can see here that they've created an app that sort of harnesses all the nutritional information that's out there and makes it easier to lure people into buying the right stuff. And so this has been a long time coming, and I would just emphasize to Dr. Kruger's discussion earlier this year about where apps are going. This is kind of a big part of the future of prevention, is how people in real time can make it easier to make these decisions. But the question is always, can it actually move the biometrics, right? And so this is something where we're looking at blood pressure and prediabetes and diabetes, and essentially a subsequent improvement in those, as well as on the other end, how do you actually pay for this? So where, in this case, what does that look like for the grocer? What does that look like for the app developer in terms of stickiness and moving things to bigger margin items? So that is your 10 minutes on food as medicine. I think this is a big part of our future, and excited to see where the study goes that we'll be doing here at the Institute. Thank you.
Thank you, Courtney. Probably time for one quick question, if any.
Sorry. Yeah.
Okay, we'll keep moving. Oh, I was worried about that. Yeah. Sit here and put it on. All right, so my 10-minute topic is going to be fish oil, which I think is a really interesting topic for a couple of reasons. One, we have lots of patients that take this. If I look at our daily census of patients in the clinic, I bet you 25 to 50% of our patients are taking fish oil. And the question is, should they be? And the thing that makes this a little bit unique is that we have a supplement here, but yet we have a lot of randomized data. That's really unusual for the supplement world. And so we have a lot of studies we can look at to see what the evidence for fish oil actually is. And so if you go back to the beginning of nutritional epidemiology, kind of the first link or the first cause that was put out there is that fat is unhealthy for us. 7-country study in the 1970s kind of proposed that the countries that take in more fat seem to have more heart disease. And that was kind of universally accepted, but there's a couple researchers in Denmark that said, wait a minute, we've been studying this native group in Greenland, these Inuit, and they seem to have a very, very high fat diet, yet they don't seem to have any heart disease. So that raised the concept potentially that not all fat intake is the same, and that potentially polyunsaturated fats are healthy for us. And so when we talk about polyunsaturated fats, do we have a pointer? Oh, all right, that'll work. So when we talk about a fatty acid, the acid end of the fat is considered the alpha end, and the methyl end here is considered the omega end. And some fatty acids have their first double bond at that third carbon. And so those are omega-3 fatty acids. And so the 2 omega-3 fatty acids in fish are eicosapentaenoic acid and docosahexaenoic acid. So that's EPA and DHA. So when you're talking about fish oil, you're talking about some combination of EPA and DHA. And it's found in most seafood, but really, it's really concentrated in what we call the oily fish. And so these are larger, cold water, saltwater fish, so salmon and trout and tuna, and mackerel, and several other fish. And there's a pretty broad range of how much EPA and DHA is in each fish, but in general, you can assume a serving of salmon is about 1,000 milligrams of omega-3 fatty acids. Now, you can also get them through supplements, correct? And through medications. And so you can get them over the counter with pretty variable dosings and variable ratios. There's 3 prescription fish oils out there. They're all approved by the FDA. They're approved to reduce triglycerides. They're not approved to reduce cardiovascular outcomes. And unfortunately, in all those studies, we've also seen a slight increase in LDL with those medications. So they lower triglycerides, but they do bump up LDL a little bit. And so that raises concern about their overall cardiovascular benefit. And then we have Vascepa, which is purified EPA, so no DHA, just EPA. And so some of the initial observational data was pretty consistent in that if you look at the Physician's Health Study, as physicians took in fish, they seemed to reduce the risk of cardiac death. But it was very much in a threshold relationship. So it's not a linear relationship. It wasn't in the more fish you ate, the better you did. It was once you got to a certain threshold, about 2 servings a week, then you reduced your risk. Taking more than that really didn't seem to help. And so Daria Mozaffarian, who Courtney mentioned before, published a meta-analysis in 2006 kind of confirming that if you look at all the data out there, it really confirms this threshold relationship. And like I said earlier, the nice thing about this is that we have really good evidence that we have a lot of trials here. So we have things we can look at. And so just in the past decade, we have 6 large randomized trials looking at this concept of fish oil for cardiovascular prevention. Let's briefly touch on each of them. So the Origin trial in 2012 was more than 12,000 individuals at high cardiovascular risk. And over 5 years, there was no reduction in major cardiovascular events. The Risk and Prevention Study Group put out their trial the following year in 2013. And again, over 12,000 people and no reduction in cardiovascular events. The Ascend trial came out in 2018. More than 15,000 people with diabetes, followed for almost 10 years. And with a daily low-dose fish oil supplement, they didn't seem to reduce their risk of major cardiovascular events. No less heart attacks, no less strokes, no less cardiovascular death. And then very recently, the OMEMI trial, which was just published in February. This is 1,000 elderly individuals who had just had an MI, so considered to be a high-risk group. And this was 2 grams of fish oil a day compared to placebo. And again, no major reduction in cardiovascular events. And so you add all 4 of these together, you have 40,000 patients studied for at least 5 years with really no evidence of significant benefit. And then also we have the VITAL trial. This is published in 2018. And this is a little bit more of a primary prevention study. So simply to get in the trial, you had to be above age 50 if you're a male, or above age 55 if you're a female. And it was over 25,000 individuals, equal parts men and women, and over 5,000 black participants. So a very diverse study. So 1 gram of fish oil a day, followed for 5 years, and there was no major reduction in cardiovascular events. Fish oil has also been proposed to be anti-inflammatory and potentially cancer protective, but they really didn't see any change in cancer either. Now, because it's such a large study, we can do a couple different things. One, we can look at secondary outcomes. And looking at secondary outcomes, there was a reduction in total myocardial infarction, which really fits with that observational data. The main benefit of fish intake seemed to be a reduction in cardiac death from fatal MI. And so we do see a small reduction there. The overall event rates were low, but there was potentially benefit that way. Additionally, you can look at it by subgroup analysis. So you can look at it in old and young, and with diabetes and without, and all sorts of things. And really, there was no group that benefited more than the other, except for in one area. And that's if they looked at it by baseline fish intake. If you did that, the people who averaged less than a serving and a half a day or a week had benefit from taking their daily fish oil supplementation. The people that averaged more than that didn't seem to have any benefit. And so again, this fits with that threshold concept. If you don't have any seafood in your diet, taking the fish oil supplement makes sense. There's cardiovascular benefit. Once you have seafood in your diet, adding more fish oil to it doesn't seem to make anything better. Taking more doesn't always make it better. And so I remember talking about this with one of the docs in the docs lounge a couple years ago. And I said, we have a lot of negative trials for fish oil. And he said, well, that's very obviously because they don't take enough of it. You need to take more. So let's crank it up. So this is the strength trial. So this was a trial just published last year. And this is 4 grams of fish oil a day compared to placebo. So that's a pound of salmon a day pretty much. And so this is a lot of fish. 13,000 individuals, again, at high cardiovascular risk and no benefit. They actually stopped the trial early for futility. And people that took high-dose fish oil, it didn't seem to reduce their cardiovascular risk. Now, one of the other things that's important here is that we kind of lump EPA and DHA together because naturally that's how they occur. They occur together. But if you look at them separately, they tend to have similar properties except for one thing. And that one thing is how they're incorporated into the cellular membrane. when EPA gets incorporated into the membrane, it seems to stabilize it. It seems to make it less likely for lipids to oxidize and less likely for cholesterol domains to form. And so there's a basic science theory you could put out there that EPA is potentially anti-atherosclerotic, that it makes plaque less likely to build up. Whereas if you look at DHA, it seems to kind of counteract that effect almost. It makes lipid membranes less stable, cellular membranes less stable, and makes cholesterol domains more likely to form. And so DHA might not be anti-atherosclerotic. In fact, it might counter the benefits of the EPA. And we do have a couple studies looking at EPA alone. So this is not fish oil, this is purified EPA. The first one is the Sglt2 trial, and so this is from 2007. 18,000 patients with hyperlipidemia in Japan, and that's important because they have a high background intake of fish, right? So if this is a threshold relationship again, we're probably not going to see any benefit. And it was a statin plus 1,800 milligrams of EPA versus a statin alone. Followed for 5 years again, pretty similar design. And if you look at lipid changes, it's important to note that with purified EPA, we see a reduction in triglycerides, like we do with EPA and DHA, but we don't see any change in LDL. It doesn't raise LDL at all. If you do purified EPA alone, you don't raise LDL. And with that, they saw a cardiovascular benefit. So we had a modest, about 18 to 20% reduction in cardiovascular events over the 5 years of the trial. So we seem to have evidence of benefit for purified EPA that we don't seem to see with a combination of EPA and DHA alone. And then more recently, we have the REDUCE-IT study. So this has gained a lot of attention because of the significant benefit that was found. And so this is 8,000 people with established cardiovascular disease or diabetes and multiple risk factors. So this is a high-risk group. They had to have higher triglycerides as well and normal LDL levels. And they were randomized to 2 grams of EPA twice a day, so 4 grams of EPA. And I have some patients say, I like the idea of taking Vascepa because it's very natural. 4 grams of EPA a day is not very natural. It's unnatural in a sense, but potentially it's very healthy. And so again, followed for 5 years, looking at a composite outcome. And there was a significant reduction in cardiovascular events. It's a 25% relative reduction, but the absolute reduction here is actually 5% in 5 years. That's a bigger absolute reduction than we see with any of the statin studies, or most of the statin studies, or any of the Pcsk9 studies. This is a large absolute reduction in cardiovascular risk with taking high-dose EPA in a high-risk population. A few caveats, or things worth mentioning. There was a slight increase in LDL in the placebo group, and that's probably from the mineral oil that they used as a placebo. It can block statin absorption in some people. And so this raised concern right when it came out. The FDA took a long, hard look at this, and they reanalyzed the data. And their conclusion was, before they approved it, is that this really is unlikely to affect the trial results. That the increase in LDL was very, very small. And they looked at the people whose LDL didn't increase, and it didn't seem to negate the benefit. And so it's probably not something we need to pay too much attention to. There was a slight increase in AFib. I would love to hear from our EP colleagues on this one. So in REDUCE-IT, and in STRENGTH, the high-dose EPA-DHA trial, and in OMEMI, that one in elderly patients, all 3 trials showed a very slight increase in atrial fibrillation. And all the prior data would say that fish oil is very stable from an electrophysiology standpoint, actually potentially beneficial. This seems to be pretty consistent, though. We see this very small increase in AFib when people take higher doses of fish oil. And then finally, if you compare it to that STRENGTH trial, that trial that looked at high-dose fish oil, in both studies, EPA levels in the bloodstream increased by more than 250%. So their EPA levels went up substantially in both studies. But yet in REDUCE-IT, as you look at your EPA level, it's inversely related with cardiovascular event rates. The higher your EPA level was, the lower your event rate was. But if you look at it in STRENGTH, it didn't see that relationship at all. It's almost as if the DHA kind of negated the benefits of the EPA at those high doses. And then also, if you look at STRENGTH, there was a 20% reduction in triglycerides. And in REDUCE-IT, there was a 20% reduction in triglycerides. So both studies reduced triglycerides by the same exact amount, but yet one had a major cardiovascular benefit and one had none. And so using fish oil to reduce triglycerides as a way of reducing cardiovascular risk, that raises some concern that that might not be the case. In all those other fish oil studies I showed you, triglycerides came down, but event rates didn't necessarily come down. So it likely suggests that the purified EPA reduces cardiovascular events through some other mechanism. And so the question is, well, what is that mechanism? And so we have a recent mechanistic study, the Evaporate Trial. So this was 80 patients who had a CT coronary angiogram that showed plaque. And so they were already on statin therapy, but they had high triglycerides. And so they were treated with that 4-gram dose of EPA versus placebo, and then they repeated their CTA 18 months later. And so these red boxes are the placebo group, and the blue boxes are the EPA group. And these are all different types of plaque formation. And so whether you look at it by calcified plaque or non-calcified plaque, plaque progressed in the people on the placebo group, whereas plaque reduced in the people on the EPA, especially in this group with low attenuation plaque. This is the soft fatty plaque. This is the high-risk plaque. And so we saw plaque regression with Vascepa, whereas we saw plaque progression without it. And so that's probably the mechanism of benefit here. Purified EPA is anti-atherosclerotic, whereas a combination of fish oil doesn't seem to be that case. So for final conclusions, I would say seafood, especially fish high in omega-3 fatty acids, is clearly an important part of a heart healthy diet. We should be counseling our patients as such. They should try and include as much seafood as they can. Routine fish oil supplementation, though, is not really supported by the large randomized trials. It's just a lot better to eat the real thing. And we see this in the nutrition world all the time. Whenever we try and get smarter than food, we tend to lose. It's just a lot better to eat the real thing. Taking supplements as a way of kind of supplementing your diet versus eating the real thing doesn't seem to be the right way to go. I think it's potentially an option to reduce the medication burden for our patients. You know, Dr. Tuohy is going to talk next about a medication class where we have really good evidence of benefit. And so we have the duty to try and get those medications to the patients who are most likely to benefit from them. Well, here kind of the inverse is true. You know, if we have the chance to reduce the medication burden for our patient, it's something we should at least think about it. And this should probably be their decision. You know, for some patients who don't eat any seafood or don't like seafood or don't have access, taking a low-dose fish oil supplement is very reasonable. But for the rest that have seafood in their diet, they don't necessarily need to take more. And then finally, you know, consider Vascepa for patients at very high cardiovascular risk. And it's important to note that this is not the same thing as fish oil. We have a lot of patients say, oh, let's take fish oil instead. That's not the same thing at all. This is a different medication. This is a different intervention. It does have cost associated with it, so we have to factor that in. But we should try and get it to the patients at highest cardiovascular risk. Thanks. Any questions? All right. Oh, yeah.
Great talk, Megan. So basically, we should recommend fish oil only to people that really do not have seafood in their diet. That's the conclusion here.
For your routine over-the-counter 1 gram a day fish oil, yes, I would agree.
Or EPA.
Yeah, if they're high enough risk, then yeah, I probably wouldn't say take more fish oil. I'd say let's take Vascepa
So
instead.
there's probably a huge population of patients that overdoes the fish oil and they thinking that they're benefiting, right?
Yeah, and it's hard because if you check those triglycerides, they come down more, right? So it's always hard to not to react to that number. It makes the numbers look better, but I mean, you know, it's not like one trial, right? We've got 6 large studies, thousands and thousands of patients. You know, at some point we have to follow the data. All right, up next we have Dr. Tuohy. She's one of our colleagues from the East. She has joined our prevention group. She's been great to get to know, and she's going to talk to us about Sglt2 inhibitors.
Thank you, Mike. Earrings are a hazard. Be careful, gentlemen. Okay. Good morning. I'm delighted to be here with you all. Is the mic working okay? Great. Elizabeth Tuohy is my name. I appreciate the opportunity to be here. I'm one of the cardiologists at the former United Heart and Vascular Clinic, now MHI at United. So welcome. Thank you. Let me see if I can find my talk. I joined the group in 2011 and serve as the medical director of our prevention clinic on the St. Paul side. Great. Well, I'm a firm believer as well in lifestyle matters most and other things that we can be doing. I'd like to review, or I was asked to review, the data on Sglt2 inhibitors and their benefits in cardiovascular risk reduction. So very big topic to try to cover in 10 minutes. I have no disclosures. The objectives will be to help you understand the mechanism of action of Sglt2 inhibitors, appreciate the cardiovascular risk reduction that we can see from these medications, and then also review a little bit of the practicalities of utilization in clinical practice. Why should cardiologists know about a diabetes medicine, you may ask? As we all know, diabetes is highly prevalent. Approximately 12% of the American populace has diabetes with variation amongst different demographics. 2 to 5% have undiagnosed diabetes they're not aware of, and as much as 34% of the population has prediabetes. And we also know that diabetes is a strong risk factor for cardiovascular events. At least 68% of people over age 65 with diabetes will die of some form of heart disease. 16% will have a stroke. And the heart disease death rates amongst people with diabetes is 2 to 4 times higher than those without diabetes. The latest primary prevention guidelines from our organizations, ACC and AHA from 2019, advise that in people with type 2 diabetes, after discussing lifestyle, eating well, exercising, that's most crucial. Second is first line medication would be metformin. And then after that is second line choice to consider Sglt2 inhibitors or GLP-1 receptor agonists. And for today's time, I'll just zoom in on the Sglt2 inhibitors. So the picture on the left demonstrates normal renal physiology, a normal nephron, where in the proximal convoluted tubule, sodium and glucose are brought together into the lumen through this co-transporter. If we block that co-transporter with Sglt2 inhibitor medication, that results in sodium and glucose remaining in the tubule and ending up in the urine as glycosuria and natriuresis. In terms of the hyperglycemic effect, this results in a A1C reduction of approximately 0.5 to 1%. It's not a huge drop in blood glucose levels, but it has a number of other effects that we think have benefits systemically. The other, beyond the glucose effects of Sglt2 inhibitors, there's ongoing studies to investigate the various mechanisms of action, but we have seen a lot of various things, including in the heart, evidence of improved energy metabolism, decreased inflammation, improved cardiac remodeling, decreased ischemia, decreased oxidative stress, and decreased epicardial fat. In the vasculature, there's evidence of decreased inflammation, lowering blood pressure, increasing vascular progenitor cells, and also improving vascular function overall. Systemically, people lose weight. There's inhibition of the sympathetic nervous system and increased erythropoietin formation. The currently available Sglt2 inhibitors include empagliflozin, which is Jardiance, canagliflozin, which is Invokana, dapagliflozin, Farxiga, and ertagliflozin, which is Sglt2. And we'll review very briefly the papers that have come out on the benefits of these medications in our cardiovascular world. The most important of these studies, I believe, is the EMPA-REG outcome study, which examined the impact of empagliflozin on cardiovascular morbidity and mortality in a high-risk group in patients who had diabetes and established cardiovascular disease. The glucose effect was that A1C decreased from 8.2 to 7.8%. But if we look at outcomes, cardiovascular outcomes, here's what we see. So on the upper left panel, the combined outcome of cardiovascular death, non-fatal MI, non-fatal stroke, there was a relative risk reduction of 14%. Death from cardiovascular cause, reduction of 38% relative risk. Death from any cause, relative risk reduction of 32%. And also importantly, decreased hospitalizations for heart failure, which is thought to be in part due to the diuretic, natriuretic effect of the medications, 35% relative risk reduction. Canagliflozin was studied in 2 different trials called part of the CANVAS program. They investigated patients with type 2 diabetes with established disease over age 30 or people over age 50 with multiple risk factors. So again, trying to find a higher risk group. When they looked at the combined endpoint of death from cardiovascular cause, non-fatal MI, or non-fatal stroke, there was at least no significant difference in non-inferiority, but a benefit with canagliflozin in the combined endpoint. If we look at those things individually, there wasn't a significant difference between cardiovascular death, non-fatal MI, or non-fatal stroke. So not quite as powerful as the benefit we saw with empagliflozin in terms of the individual endpoints. But here with canagliflozin as well, there was also a reduction in hospitalization from heart failure. Dapagliflozin was evaluated in the DECLARE trial, over 17,000 patients with established disease or multiple risk factors followed for over 4 years. And here we also saw just basically non-inferiority with dapagliflozin compared to placebo in the combined endpoint of major adverse cardiovascular events. If they narrow that down to looking at cardiovascular death or hospitalization for heart failure, there was indeed benefit with dapagliflozin. And that was really driven by the benefit in the reduction in heart failure hospitalizations. There we saw an absolute reduction from 8.5% in the placebo arm to 6.2% of patients in the treatment arm. And there wasn't a huge difference in cardiovascular death in just looking at cardiovascular death. So again, that benefit was driven by reductions in heart failure hospitalization. Lastly, ertagliflozin studied in over 8,000 patients with type 2 diabetes and coronary disease, followed for just over 3 years. And here we saw no significant difference in major adverse cardiovascular events. Non-inferiority, but not necessarily a benefit from overall MACE. But again, there was a significant reduction in heart failure hospitalizations. So when we think about the benefit of a very specific expensive medication, it's also important to compare what are the adverse effects and the overall pocket costs to our patients. The most important adverse effect with the glycosuria is the risk for urinary tract infections and genital yeast infections. That occurs 50 to 20% more often in patients on the treatment arm compared to placebo. So a definite signal of increased adverse effect, affecting women far more likely than men. There can also be urethritis and vaginal irritation without overt infection. The diuretic effect can result in hypovolemia or even orthostatic hypotension. So being mindful of that with patients who already are euvolemic on your wonderful diuretic regimen, that adding this medication will add a little bit of a diuretic effect. Being careful in the elderly to avoid orthostatic hypotension. And there's a slight increased risk of diabetic ketoacidosis. In the canagliflozin study only, we saw an increased signal for lower extremity amputations, toes and distal foot amputations, and that was not seen in the other medication trials. So it's recommended to use canagliflozin in caution in people with neuropathy or a history of foot ulcers or other foot deformities. And the mechanism of action of that is not well understood from what I understand. Contraindications to treatment are those with type 1 diabetes or people with a history of DKA. And then we have to use precautions in patients with chronic kidney disease to be mindful of which medications are appropriate in those with a reduced GFR. Empagliflozin and dapagliflozin can be utilized in patients with a GFR under 45. Excuse me, I misspoke. It must be discontinued when their GFR drops under 45. Whereas canagliflozin can be used at its lower dosing range of 100 milligrams daily up until the point of dialysis. Ertagliflozin needs to be discontinued when the GFR is less than 60. Cost is another consideration. This is according to GoodRx.com this weekend when I checked prices. The monthly cost of empagliflozin, canagliflozin, and dapagliflozin are approximately $500 or just above. Ertagliflozin a little bit less expensive. We might say the data is most compelling for empagliflozin. We want all of our patients on that medication, but currently insurance formularies will largely dictate which Sglt2 inhibitor your patient can receive. So when starting, me being a cardiologist now in practice, it's a weird feeling to think about prescribing diabetes medications. And I think it's important, though, for us to recognize the benefits these drugs can have in high-risk patients and working in combination with the patient's team. So if I discuss with the patient's primary care provider, hey, what about this idea, or their diabetologist, endocrinologist, we can work together then to see if their other medications need to be modified. If a patient with type 2 diabetes is also on insulin, for example, their insulin needs will go down with adding an Sglt2 inhibitor, or we might be able to have the opportunity to stop their sulfonylurea, something like that. Similarly with diuretics, as I mentioned earlier, there might need to be a reduction in their diuretic regimen with starting this type of medication. So working as a team. Thank you. Any questions? We got to get Dr. Knickelbine to clinic, so I'll turn over the mic.
I do have one or two comments. Regarding the chronic kidney disease, there is caution about people with low GFRs, but there also is a dapagliflozin study in people with CKD that showed clear evidence of benefit in terms of renal outcomes, including all-cause mortality. And so I think we always use them in caution, especially if their CKD is unstable. But for stage 3 stable CKD, I think it's probably an indication, in fact. And the only other comment I was going to say is that we talked about this, I think, 2 years ago at Grand Rounds here, pre-pandemic. And, the data just continues to come out, and it's like the fish oil thing. You got to follow the data. I think we're at a point now where these medications, they're not for a prevention clinic. They're not for heart failure clinic. I think they're for all cardiology clinics. This is a medication that definitely can improve cardiovascular outcomes, and I think we should get comfortable with them.
Absolutely, and for the sake of time, did not review the benefits and renal outcomes as well as heart failure outcomes. There's a lot of data to suggest the benefits in many settings for our patients.
Can you just comment, I suspect you guys use it more than most of us. How do you dovetail that into kind of what the primary care provider's doing?
Yep.
It seems like we're getting in their space a little bit.
Yeah, Tom's question about how do we interact with primary care on this? And I agree, it's a little tricky. And I was uncomfortable at first, but over time, I think they're getting more comfortable with medications. They're more familiar with them. And so now I tended to send them a note saying, hey, I started them on this medication. I'm not going to adjust their insulin. I'll leave that up to you. I tell the patient you might need to have it adjusted. And so as long as there's some communication, I think overall it's been going better. So thanks, Dr. Tuohy. I gave her the hardest topic by far.
Absolutely. Thank you.
All right, Dr. Knickelbine is going to finish us up with a lipid update.
All right, and I see somebody in the audience that knows as much or more than all of us. Welcome, Kevin, about lipid management. Let's see, page. So there have been some updates in this area over the past couple of years. The treatment guidelines have been updated. The American Heart Association, American College of Cardiology are the US guidelines. Those were updated in 2018. The Europeans have updated their guidelines 2019, so you should be aware of some important updates there. And also we're seeing kind of an explosive expansion of treatment of lipid lowering and various targets with new science and technology that's really exciting and unique. But I thought I'd show a case to maybe exemplify some of these changes in the guidelines. This is a 64-year-old male who had a recent acute coronary syndrome and has multiple risk factors: diabetes, hypertension, kidney disease. And he's on high-intensity statin therapy at 40 milligrams of rosuvastatin and has achieved a 53% reduction in cholesterol, which historically we might consider an adequate response, but has a current LDL of 74 and normal triglycerides. And I guess I'll add that, is eating 2 servings of fish a week. So according to the new guidelines, what is the next best option? Are we going to add Isipa, as Mike talked about? No further treatment because we've achieved that 50% reduction. Are we going to add Zetia, 10 milligrams, or add a Pcsk9 inhibitor? Maybe keep that in the back of your mind as we go through this. As far as the therapeutic target in these guidelines, it really does remain LDL, and that's because as you, let me see if I can get the arrow in here. As you lower LDL exposure in multiple trials through time has shown us a causal and cumulative effect of LDL lowering on reduced proportional risk reduction in coronary heart disease. So as far as the therapeutic target in these guidelines, it does remain LDL. And so what's new about these guidelines is they did get together with some of the other societies. One of the problems in this area is you have the American Diabetes Association, you have the National Lipid Association, you have the American Heart Association, and the American College of Cardiology all sort of having their guidelines. They did get together and agree to support these guidelines in 2018, which I think was helpful. They still have their own guidelines, and there are some differences, but they did support this general concept. And one of the important things that we deal with probably most frequently in cardiovascular disease is how to treat the high-risk patient, or the patient who has already had a cardiovascular event. And importantly, in these guidelines, you now have a new category of treatment called very high risk. And it's not just a matter of having ASCVD, but it's having ASCVD, either multiple ASCVD events or high-risk conditions. So they define ASCVD events as an acute coronary syndrome within the past 12 months, a prior myocardial infarction, prior ischemic stroke, or symptomatic peripheral vascular disease, and a high-risk condition as being above 65, having FH or a prior CAB or PCI, diabetes, hypertension, kidney disease, kind of like the patient I showed you, currently smoking, a persistently elevated LDL, or heart failure. And how you defined high risk was multiple major ASCVD events, so more than one top left box, or one top left box with at least one major high-risk condition. Importantly, this isn't a one-time assessment, so these patients will probably evolve from high risk to very high risk and may need different treatment. And then the algorithm, they did split up ASCVD not high risk on this side with those in this very high risk category now. And age was not a consideration in the very high risk group. So if you're in this very high risk group, they want really aggressive treatment. And I'll go through exactly what they recommended. But if you're not in the high risk group, we go back similar to the 2013 guidelines where we look at age. And specifically in this group, if you're less than 75, high intensity statin first with potential add-on therapy with Zetia and statin, or if you're greater than 75, again, kind of a provider-patient discussion about the risks and benefits of either moderate or high intensity statin. But if you're over here in this very high risk group, like our patient, they want you to get more aggressive. And high intensity statin are maximally tolerated. And if the LDL remains above 70, even if you've gotten that 50% reduction now, adding Zetia or a Pcsk9 inhibitor should be considered. And the guidelines sort of recommended Zetia first approach due to cost concerns, although I will say the price of the Pcsk9 inhibitors is coming down every year. They started at about $14,000 a year. They're down into the, I think the pharmacy is paying around the $2,000-3,000 range. So they're clearly more expensive than Zetia, but they're coming down nicely. The other thing that I like to do when I'm seeing somebody is try to think of where I'd like to be and what % reduction I'd like to get. So we're very familiar with moderate and high intensity statin therapy getting us in that 30 to 50% range. If you add Zetia to a high intensity, you can expect about an additional 15% reduction. But a Pcsk9 inhibitor alone, for example, can provide a 60% reduction. And when you combine it with a high intensity statin, up to a 75% reduction, and then all three, 85%. So having in your mind sort of where the patient is, where you need to go, helps you figure out which of this kind of soup you want to move towards. Now, the ACC-AHA is obligated to consider randomized controlled trials. The Europeans, though, they tend to look at kind of the existing data in total. And they have a different guideline. And this is one study that they may have considered along with others. This is the Glagov trial. So they added a Pcsk9 inhibitor and looked at plaque change. And much like Mike was talking about with fish oils, you can see here that the change in plaque volume, anything above 0 meant it progressed, and below 0 meant they got plaque regression. And that's a big thing for my patients that come in a lot and want to know, can we make this better? And it turns out you can, and there are multiple ways to do it. And from a therapeutic standpoint, an LDL, it looks like you really need to get your LDL below 60 to have a 95% confidence limit to get that regression. That's one important feature. And then also, as you get lower, you seem to get more regression. Now, the outcome studies are looking very similar to that. So that was sort of a surrogate plaque. And now you have an outcome trial, the 4-year trial, 25,000 patients over 3 years, looking at hard cardiovascular endpoints and showing kind of this similar effect, where as we lower LDL, both primary and key secondary endpoints, we start seeing less events. And this was also modeled in the Odyssey trial with Praluent. This is Repatha, one of our Pcsk9 inhibitors that we use a fair amount of here. So I think the Europeans, maybe they got it a little bit more of an aggressive stance because of that. So here was their old guideline in 2016, where they recommended an LDL much like the ACC-AHA at 70, but now in their 2019 guideline has a 55 in this very high risk group, likely because of what we just looked at. And so going back to our patient, potentially adding Vascepa would be a reasonable idea, but it's not in the guideline. You can do that, but it's not in the guideline. And the question was about the guideline. No further treatment because the patient has achieved a 50% reduction. That was the old guideline. That was the 2013 guideline. And in this case, we want to add something. And the guideline suggests we add Zetia, but I'd have a threshold to consider a Pcsk9 inhibitor based on that response. And then finally, to kind of end things, this is a very exciting area that the foundation has been actively involved with for years in supporting research around emerging treatments for hyperlipidemia. This is a whole talk in itself, but just kind of give you a highlight here. It's kind of an interesting mechanism where if you look at the statins have been targeting production of VLDL on the HMG-CoA side. There's a new medication, bempedoic acid, that is inhibiting this acetyl-CoA up just north of statins, and that just came out. Pcsk9 inhibition is traditionally been with a monoclonal antibody here. You get a marked increase in your LDL receptor density. You actually just sort of naturally remove your LDL. You're making your liver do a vacuum job, so to speak, kind of on your LDL, go out, increase your receptors and pull it back in. And then you can also, this is kind of where the exciting part is, in gene silencing. And gene silencing we're seeing a lot of in therapeutics, in cardiology, and in particular in lipid lowering. And that's where you go to the messenger RNA at the nucleus level and you tie up the transcription of something in particular that you want to modulate. And right now, the big one that's coming down the pipeline is inclisiran. That is going to be a gene silencer for the production of Pcsk9 here. And there's others as well, but that's sort of an overview of where this is at. Here's a little bit on the, they call them small interfering RNA molecules, or siRNA, to Pcsk9. Orion was their study, and they got a persistent decrease in LDL. It's not quite as prominent as the monoclonals, right in the 50% range. But the nice thing about these is that it's given twice a year. So if you come into the office, you'll get an injection, and then we'll see in 6 months, and we know you're going to have a 50% reduction. So both the monoclonal antibodies and inclisiran, we see very high adherence with this. If you're asking somebody who's 75, 80 years old to take a tablet once or twice a day and make sure you take it before bed and don't take it with food and put it next to your toothbrush, they forget. Adherence turns out to be a very important issue. When you're giving injectables, we have very high adherence with the twice monthly Pcsk9 monoclonals right now, and we'll also have that with inclisiran. But it turns out adherence is as important as intensity, not just in LDL lowering, but here you have a high intensity statin therapy with low adherence. A non-adherent patient really doesn't result in the kind of benefit as opposed to having an adherent patient. So moving into a system where people can be injected in the office or at home will improve adherence. And last slide here, a summary of kind of where this is at, these targeted mRNA degradation by these siRNA drugs. The first one I mentioned was the Pcsk9 siRNA. That is inclisiran, Novartis, which results in both a reduction in LDL and a reduction in LPA. The Pcsk9 inhibitors do that as well, reduce lipoprotein A. ApoC3 is actively involved in lipoprotein lipase, which is triglyceride metabolism. So if you inhibit ApoC3, you get a marked reduction in triglycerides. That drug is being tested right now. ApoA, or lipoprotein A, we're hearing more about that at the meetings. We're hearing more about it in the literature as being a strong risk factor for cardiovascular disease. And the Heart Institute is actively participating, and Christine answers any questions about it. The Horizon trial. So you will use a siRNA that's given, I believe, twice a month injection to inhibit in patients with acute coronary syndrome or prior myocardial infarction with a lipoprotein A greater than 70. And they can be enrolled in this study to see if we can inhibit ApoA production directly and improve their cardiovascular outcome. ANGPTL3, you might see this one as well. Even Acumab, they did a small trial that we participated in that reduced LDL 50% on top of max statin and a Pcsk9. That's a lot of LDL lowering. They're also testing it now. We've been invited to participate in a triglyceride lowering study. So a lot going on in the space, pretty exciting.
Thanks, Tom. That was great. And yeah, Tom has done an excellent job. Clearly the landscape is changing a lot in this field, and so he's been great at keeping our trials moving and getting involved in the newer studies. Questions?
Tom, thanks. Let's say you have a 60-year-old patient who's had a ST elevation MI. What is your LDL cholesterol goal for that patient?
Yeah, so I mean, I think that gets into, are you a guideline-based practitioner or are you going to look at the data yourself and kind of make a decision? And if you are going to use a guideline, are you going to use the US guideline or the European guideline? When I have these, I mean, for me personally, I sort of think the Europeans are a little ahead of us on this. The American, I mean, Mike's been on the committee, so I mean, he knows they get hampered a bit by having to look at randomized controlled trials. If you look at the data in total, really, there's not a downside to going low. I didn't show it, but in 4-year, they looked at the patients that got down to LDLs of 20 and 30. They didn't see problems. They didn't see brain issues. They didn't see cognitive issues. They actually did cognitive testing. It was called Ebbinghaus, and they did okay. So I mean, in that patient, I'm definitely, based on Glagov, I'm going to go below 60, and I'm more of a European flavor, and I'd shoot for 55 or below. I don't know about you, Mike.
Yeah, I guess I would just approach it from the standpoint of simplicity of, we have really good safety data for statins and for ezetimibe, and they're both cheap. So I would start with 40 Rasuva and ezetimibe and see where they end up. If their LDL ends up at 90 and they've got other risk factors, I'd probably go to the Pcsk9. If their LDL, the LDL goal thing always is a little bit tricky to me, because let's say they get to 61 or 59 and my goal was 60, it really doesn't matter. It's more about what was their absolute risk reduction and what's their whole clinical picture too. If they were a smoker with high cholesterol, and now we've dramatically lowered their cholesterol and they're not smoking anymore, and their LDL is 61, they have to be less than 60. I don't know if I'd add the Pcsk9 then. And so I guess I try and take each patient individually. But in general, I think, yeah, the idea that if you get to 70, there isn't further benefit in going to 50, I don't think that's the case at all. I think the evidence would clearly support that there is. And even going lower than 50 seems to be beneficial in some people.
And also, that's a good point. This isn't in a vacuum. I mean, we have a dropping HDL during COVID is what I'm seeing. People are exercising less. They can't go to the gym. I kind of you have to work on that. Triglycerides, I mean, clearly are a marker for truncal fat, carbohydrate intake. You have to look at in total. I mean, not just the LDL.
And that's one of the challenges we're facing, is that same patient might be a reasonable candidate for a Pcsk9, they might be a reasonable candidate for Vascepa, and they might be a reasonable candidate for an SGLT2, and they could probably only afford one. And we don't have any comparative data there, and so it's a little bit tricky. It's an open conversation with the patient. Carol?
A little global question to, I guess, all the speakers, but many things that you guys said, obviously it's pretty recent, great trials and great data. Did the majority of the stuff made it to the guidelines at this point? And that's first part of the question. And the second is, what's the adherence within like the general cardiology community to this, or / guidelines and family practitioners?
Yeah, I guess I'd say, cardiologists tend to be pretty lipid-centric, so we're pretty up-to-date with most lipid data. I think 3 years ago was the first time I addressed the concept that we should maybe start treating diabetic risk factors, and that wasn't very well received. We're used to primary care and endocrinology managing diabetes, and so I think it depends on the risk factor a little bit. We tend to do pretty good with lipids. We're okay with blood pressure, and we're not very good with diabetes for whatever reason.
Yeah, I would say, we try, and we don't do very well. I mean, this guy here knows, because he looked at some of our data here at Alina, and in terms of on a national basis, how do we even get to the guideline level? We're pretty poor. The ASCVD group, very high risk, it's probably still in the 60 to 70% reaching those goals alone. So there's a lot of work to be done in just achieving the guideline levels. And then going beyond the guideline levels, that's a whole nother story. But I think we should focus on, let's just get people to the guideline levels and figure out why we aren't achieving those endpoints. There's a lot of factors: adherence, statin intolerance, blah, blah, blah. But we don't do a very good job of it.
In 2013, across the line, prior to the release of the 2013 cholesterol guidelines, which were kind of the big switch to this kind of risk-based approach, 60% of people who were eligible for a statin were on a statin, and 5 years later, 61% of people were on a statin. So we have work to do.
But we have tools. We showed them to you.
All right. Thanks, everyone.
Yeah.